We shall start with our first speaker, Dr. TAMILARASI, who's a senior consultant cataract and IOL services at the Eye Foundation Group of Hospitals. He's also a surgical trainer and is an extremely prolific, versatile surgeon and has an excellent concept in what ophthalmology actually means in all its terminologies. And she's going to start off with a very simple topic, which is so quintessential to doing a good SICS surgery. And she's going to be talking on premature entry, scleral disinsertion, buttonhole, how do I manage all these dreaded moments. On to you, Tamil.
Thank you, ma'am. Thank you for your kind words. Very good evening, all. Today, I'm going to talk about managing tunnel complication. A key aspect of small incision cataract surgery is the structural integrity of the tunnel. It means the tunnel has to be self-sealing. The second important aspect is the magnitude of astigmatism we are going to induce or correct with our incision. As I said, like managing complication, if you are going to have a buttonhole, we can easily say that make a superficial tunnel and proceed. And if you end up in a premature entry, reform the AC, create a superficial tunnel, and in the end of the surgery, suture the premature site. Or if you have a scleral disinsertion of your groove, suture it completely and shift to another site and proceed. But I feel this is truly a preventable complication if attention stays behind the principles of tunnel construction, which I'll be talking in the subsequent slides. So the first and foremost important thing is the patient positioning. See, the upper right video shows a superior sclerocorneal tunnel video, and the upper left is a temporal. So for a temporal sclerocorneal tunnel, I always keep the patient head with the iris parallel to the floor, chin in a neutral position. For a superior tunnel, I lift the patient's chin little up. This gives a better positioning and the surgical view. Whereas the lower left shows that the head is down and chin is rotated down, and the surgical view is also not going to be great, and the positioning and maneuvering of the crescent blade is going to be difficult, and we can have a complication, which I'll be showing in the subsequent video. The second important thing is, if a surgeon is going to see better, as a surgeon, we are going to operate better. So conjunctival dissection along with tenons plays an important role. For a beginner surgeon, I advise always to give a small relaxing cut in the extreme other end so that the conjunctiva does not fall back, and give a judicious cautery of the bleeders so that the oozing is not there. For superior tunnel, we can also, the superior rectus brittle suture plays an important role where it rotates the eyeball down and also gives a traction for performing the tunnel. The second key aspect is a fixation. Hold both the conjunctiva and tenons together and never press down. Lift it gently. And I discourage holding the tunnel lip because it can compromise the structural integrity of the tunnel. Another way to get a good fixation is making a small posterior scleral groove, and holding this gives a better fixation and counter traction for tunneling. The third important point is the incision site, size and shape. Site, a beginner surgeon always have to keep in mind the anterior limbal border and measure 1.5 to 2 millimeter behind it. So this is the site of the incision. And the shape and size for a beginner, it is always to go with a straight incision, which is around 6.5 to 7 millimeter. Later on, they can modify the size and shape depending upon the nuclear density and the method they are going to use for nucleus delivery. If they are planning to do a frown incision, they can take a central point which is 1.5 millimeter behind the anterior limbal border, and the two extreme points 1.75 to 1 millimeter behind this, so that when they're connecting the three dots, they will end up in constructing a frown shaped incision. The fourth point is next is to achieve the correct plane of the tunnel construction. So with the tip of the crescent blade, sweep from end to end of the groove, so that this acts as a windshield wiper movement, so that we can achieve a uniform plane. So once you get a plane, the next step is to assess the depth. This is a critical step to prevent a tunnel complication. So look for the visibility of the crescent through the sclera. Here the visibility is not there. That means the tunnel is deeper. If it is translucent and if the roof is bunching up, it means the tunnel is superficial. What we want is a transparent looking crescent through the scleral upper roof. So once you confirm this, proceed with the tunnel. Again, I'm re-emphasizing the fact with these two videos, whereas the upper right, you can see that the roof of the tunnel is also moving along with the crescent manipulation, and it is the view, and the view of the blade is translucent, so it is superficial. Whereas the lower video shows that the tip of the crescent blade is not even seen, that means deep. So stop here, again find a correct plane and then proceed to avoid a tunnel complication. The starting site preference, I usually start in the center of the tunnel and then sweep on either side across, but it is the individual surgeon's preference. If a beginner surgeon always have a problem towards the right side where a surgeon ends up in a buttonhole or a premature, I would advise them to start from the right extreme end of the tunnel and sweep across the other side. So it is left to the surgeon's preference. While completing the sclerocorneal tunnel, so always we have to take into account of the change in the curvature from the sclera to the cornea at the limbus. So at the limbus, the surgeon has to keep the heel down to account this of the change in the curvature. Otherwise, he will end up in a premature entry. And the second change in the curvature happens when we are tunneling towards the sides. So always tilt your crescent little bit. If this is not done, if the crescent is going to be straight, as shown in the red arrow, we can have a buttonhole on the extreme sides. So take into account of these two change in curvature while doing the tunnel. And the extreme end of the tunnel, always do a good side pocket so that it can accommodate the larger grade nucleus. Another point to be kept in mind is keep the crescent always straight. Never tilt the crescent too much. Here you can see towards the left hand side the crescent is being tilted too much, so another groove has been created rather than the intended groove which is already made. So always when coming out, keep the crescent straight and then come out like this, and don't tilt the crescent. The next step is the keratome entry. So keep the tip of the keratome at the anterior end of the tunnel created, dip in, enter, and then cut during forward movement. So what we expect is a smile-shaped inner lip, which is larger than the external groove. So the shape of the tunnel is almost like a trapezoid. Here I'm going to show videos of tunnel complication. Here we can see that while starting with the tunnel construction, you can see that the roof is moving. It's almost it's superficial, and the attention is not paid here, and the surgeon is continuing the tunnel construction. And you can see that the tunnel, the crescent visibility is more towards the left hand side, and a buttonhole happens while subsequent tunneling. So stop here. Since it has been started in the center, so the trainer is correcting from the left hand side. So once you're done, first assess the depth if it is correct, and keep in mind of all the principles which we discussed now, and proceed with the tunnel construction, keratome entry, and then complete the case. This is another case. You can see that the groove is little posterior than expected. It is around more than 2 millimeter. And while starting tunnel construction, the depth appears correct only. Here it is not superficial. But what happens at the limbus, excessive tilting of the crescent, thinking that the heel has to be down, the surgeon is tilting, so it is almost like a buttonhole there. And you can see this red dot, which is towards the left hand side, is a buttonhole which has happened. So to go past this buttonhole, tilt your crescent, lift the heel, and then create a plane behind this superficial buttonhole. So it is being tilted. So we are getting a deeper plane behind this buttonhole, and we can create and then proceed. So we are getting another new plane behind this small buttonhole which has happened. So this is a case of a premature. We can see that the visibility is not at all there, and a small premature has happened. So if a premature happens, the first step is to reform the AC. Take care, you're not going to damage the iris. And once the AC is reformed, again create a superficial plane. Look for the visibility of the crescent. Once you confirm this, take into account of the two change in curvature, and then complete the tunnel. And while placing the keratome, make sure that it is placed in the new plane, not in the deeper plane, and then cut. And always suture the tunnel at the premature site so that the tunnel integrity is not compromised. This is the case which has been showing in the first, where the head positioning is not correct, the chin is down. So you can see that the positioning of the crescent becomes a problem here. So the positioning, the heel is always up even from the beginning of the tunnel construction. So the tunnel is always deeper. You cannot see even the crescent visibility. And while maneuvering, a premature entry has happened. So whenever a surgeon has a complication, it is better to review the video, assess why it has happened, so that they can learn from their mistakes. So as I said, the premature entry, create a superficial plane and then proceed with the case. Scleral disinsertion, though rare, whenever we are making a groove, always make sure that it is done in one step. So here the surgeon is deepening the groove at multiple times, even with the blade and also with the crescent tip. And while doing the sclerocorneal tunnel, the surgeon is having a little suspicion that the AC is little shallow, but with hesitation, the tunnel is being continued. And to note that the uveal tissue has started to prolapse from the groove, and also a bleeding hyphema has also happened. So this is a scleral disinsertion. So we have to suture the groove completely and shift to the temporal side. The last point which I want to emphasize, whenever the tunnel integrity is compromised, never hesitate to suture the tunnel. Thank you for the opportunity.
I think it was just a terrific video. I mean, every single point has been beautifully brought out, and I look forward to thoughts of our expert panel on this. The very first question which I would want to ask is, any of the expert panel could answer. When you are trying to train your trainees, we know that whether it's a tunnel construction or the rexis are those critical parts of SICS surgery. So how do you go about training them? Yes, Dr. Debati.
Yeah, I think the best way to train is on a wet lab where you use a both side and you can do all the maneuvers that Tamilasari, the doctor, presented so well.
Yes.
And essentially, there are certain points which have to be put into their mind before, they go through the whole exercise. Dr. Tamilasari actually mentioned most of them and in a very nice way. I would have one or two observations. One is, the external incision is very important because the external incision actually leads to the scleral tunnel. And in case of a beginner, what happens is they are a little shy. So when they make an incision, so the initial part, that is the left side of the beginning of the incision, is usually a little shallow. Whereas because our eye is like a globe and it is curved more in the center, so even with the same pressure in the center, the external incision becomes a little deep. So a conscious effort has to be made, and that is why we have a buttonhole in the center and a premature entry in the center and a buttonhole in the peripheries, because that is where, because of this curvature. So these things have to be brought into their mind. And the most important thing, which doctor has already mentioned, is the fixation of the globe with the forceps. And in fact, you have to constantly keep in mind that whatever we are doing, suppose we are making the first split of the external incision into the scleral tunnel. So if we are moving from from left to right, then the forceps actually holds the globe and gives a counter traction from right to left in the opposite direction. So in that case, it makes the workability much more smoother. And the third point that I would like to add is essentially the internal incision is most important, because if this internal incision, that is the corneal valve with the internal incision, if it crosses the limbus, then the incision becomes not self-sealing. So essentially, when the first entry into the anterior chamber, the keratome must be absolutely parallel to the external incision. So then we get a cut which is absolutely parallel, and then we can enlarge it on either sides. But if we go, say, suppose we go from 2 o'clock to to say 7 o'clock. So if we go in this direction, then it will be diagonal, the internal incision, and then it will create a corneal valve which will run into the periphery at some point on the right side. So these are the problems which we have to instill into their mind before they really, because I mean the incision is the main thing in SICS. We have done a good incision, then the rest of the steps are very easy to follow.
But
Thank
if
you.
the conjunctiva is very thin, how
Yeah.
do you deal with that moment?
Conjunctiva, so you are taking away, Chitra. So conjunctiva and tenons have to be neatly cut and kept aside. What you hold is the sclera. So you don't hold the external lip of the
No, I
incision.
meant the part when you're fixating the globe. On that side,
Yeah.
the conjunctiva is not cut, no?
No. But you don't hold the conjunctiva or the tenon, or you hold the sclera.
Yeah.
You hold
You have a deeper hold.
the
Yeah.
sclera, and actually the forceps, the quality of the forceps also matters. I mean, for everybody's notice, I would say that, keep a good forceps. It's a 2-in-1 corneal forceps, 0.2 millimeters. The model number is F109. It was previously an Einor make, but I think now the Epsilon people make it. So that forceps is you need to have a good forceps.
Dr.
In
Boramani,
case somebody is not using the superior rectus suture, Dr. Boramani or Dr. Amulya Sahu will say and will vouch by that actually we have done away with the superior rectus suture.
Yeah.
Yes, Dr. Boramani.
Yeah, I have a few comments. As Dr. Devashish rightly said, for the dissection, you have to keep the curvature of the globe in the mind. Many times a beginner, they just keep moving the blade in a horizontal fashion, but you have to go in a curved fashion, and the nasally, the globe is more curved, so that you have to keep it always in the mind. Secondly, I don't remember whether the speaker told about this, because in between I got a phone call. The globe should be well pressurized. When the globe is well pressurized, either with AC maintainer or viscoelastics, then the walls of the sclera are properly stretched, and then the dissection becomes easier. Like if you want to cut a cloth, you always stretch the cloth and then pass the scissor. So similarly, when the walls of the sclera are stretched, then dissection becomes easier. And especially when you're doing the wet lab in goat side, this is forgotten, because the goat side, they become very flaccid. So to inject some fluid or viscoelastic, make the wall very taut, then the dissection becomes very easy. And third observation is that now we should stop taking the bridal suture, superrectus suture, because in olden days there were no good speculums. Now we have got very thin, lightweight speculums. The retraction is quite good. So superrectus suture is an unnecessary trauma to the eye. It is not required at all.
Do you all have Satyajit? Would you want to take a question? Satyajit?
We'll go ahead, ma'am.
There is one other question I have. When we are talking so much of tunnels and all, since would you believe there is any role of a guarded knife which will exactly define the depth of the process? It's not commonly being used at all. I just wanted to ask that question.
Yeah, I mean, you should be doing 1/3 of the incision. So, I mean, say about 200 micron guarded knife that would be perfect. But as I told you, and as Dr. Boramani also emphasized, that you have to keep in mind that the top of the globe, that is the middle part of the incision, and is more curved than the periphery. And usually we tend to be shy on the periphery, and same pressure, we would get a deeper incision in this. So obviously a guarded knife helps in this direction, but there aren't any in the market. And I think most of the surgeons learn it by themselves. And so that is the situation. But yes, I mean, the recommendation is well taken. The other thing, Chitra, I would like to make, is because we are right-handed persons. So essentially, the center of the incision, because we have this carrying angle, and the lady surgeons have more of that. So, the vectis or any instrument will go a little diagonally into the incision. So the incision has to have a off right center, meaning if you are doing a superior incision, it shouldn't be 12 o'clock, but it should be more towards the 11 o'clock. I think I was clear on that.
Dr. Chitra, Dr. Chitra, I want to make a comment. There are guarded knife available with shrinkage. I have used quite a lot of them, and I've found it very useful in some cases. So although we use a bar Parker knife, 15 number blade for making the incision. And as you all know that the surgery of any kind in cataract surgery, as is mentioned in Stallart's book, textbook of surgery, they say that as goes the incision, so goes the surgery. So incision is very important. Only thing one more thing I would like to add is that if you are making a temporal incision, you have to be slightly closer to the limbus in comparison to what you make in the superior aspect. That's all I wanted to make.
Yes. Should we move on to the next talk? Dr. Boramani, you have one point? We can.
Yeah, to make one point.
Yeah.
See, incision is the heart of the SICS surgery, and it is the incision where it differs from phacoemulsification, incision and the nuclear delivery. Now we have talked about how to learn. So in how to learn, I want to add one more thing. Now this SICS simulator training is available in India with help of ISM, SICS and HMS. It is always available in our CCC conferences. A center is there in Mumbai. One more center has started in Pune. Very soon there will be a center in Guwahati. So before even touching the goat's eye also, I think this virtual experience is a real life experience. And even if the teachers train their students for training, many times the teachers are reluctant because there is a manpower loss. 1 week the student will be away from the hospital. But if a beginner learns on the simulator, it saves a lot of time of the teachers in the training because they become almost partially expert in doing the human eye. So everyone should take the benefit of SICS simulator training.
Okay.
A few comments I have observation of mine. Now this videos were, as I saw, I think the learner's video, but the teacher has taken the right correction there. And I saw somewhere they have given a smile incision, which should not be done. Second thing is that from limbus 2 millimeter should be avoided because the maneuverability becomes difficult. So those are the things, but otherwise the teacher was correcting those things. If a premature entry is there, how to manage it, all those things. Was a very learning video for beginners. So that much I want to say. And the other things I think, but Devasis and Varamani, they have covered it very well. Thank you.
That was a wonderful video, Tamil, and
Dr. Chitra, can I just make a small comment in addition to all points are very well taken.
Yeah.
One or 2 points is when she was holding forceps, she was holding in different areas every time she was manipulating. She came back. It's better to identify the most, ergonomically correct position and relatively avascular position. She was holding right at the limbus, which is the right place. Many people hold it far away, and at the limbus, the conjunctiva, tenons, and sclera are firmly adherent to each other. So you should hold it very close to limbus, and hold it at the same place every time. And as Dr. Debashish said, it has to hold the sclera, not the conjunctiva. The teeth should be protruding like teeth of a mouse, and it should hold the sclera so you get good stability. I would suggest everybody to start from temporal side instead of going from the superior side. It's very easy to shift over or start from temporal side. Third is the crescent blade itself is too long. When you are going there, there's a lot of additional length is there which will hurt the lids, which keep touching the lids, and patient will have sensations of the heel of the tunnel blade touching the lid, which can be avoided by selecting a tunnel dissector, which is shorter in length. And the most important thing to get a good suction is neither the forceps nor the blade should be either dragging the tissues up or to push the tissues down. They should keep respect the normal anatomy, circular globe-like anatomy of the eye without any compression or elevation. and both the eyes come into picture. Then if you do that, and your plane should be uniform. The last point is the sharpness of the blade, which is very, very critical. I would appreciate the younger people who are starting should not go for a very, very sharp blades, new blades. They should not go with it, because sharp blades will find out their own way of getting wherever they want. The blades are, say, 2-3 times autoclaved, and you pick it up, and they respect the tissue planes much better than very sharp blades.
Yes, thank you very much.